Hello everyone, today's topic is insulin and oral antidiabetic drug. This is the fourth video on the topic. In today's video, I will be covering the therapeutic uses and adverse effect of the insulin. Now, where we are going to use this insulin. So, of course, the first and most important use, it is a diabetes mellitus. Okay, both type 1 and type 2 दोनों में ही देना है. We can use in both. And when to give in type 2 diabetes mellitus? When it is not controlled with the dietary modification, it is not controlled with the only with the oral antidiabetic drug, patient is underweight, then to tide over the infection, trauma or surgery part and during pregnancy. These are the few indication of the insulin in type 2 diabetes mellitus. Okay. Now, how much dose is to be given? Again, it is tailored. It differs from individual to individual. So, requirement of the insulin in both type 1 and type 2 diabetes mellitus, it all depends upon the blood glucose level. But still they say in type 1, in most of the patients, we need 0.4 to 0.8 unit per kg body weight we give, and whereas in type 2, we give 0.2 to 1.6 per unit kg. But this dose again vary from person to person. Now, how we are going to give, what kind of regime we are going to follow. So, there are two type of regime we follow. One is split mix regime and another one is a Basal-Bolus regime. Now, in split mixed, we have split the dose into two doses. They are given of what? Of mixture of regular insulin with neutral. Mixture देना हमने. And two doses कैसे? One before breakfast and another one is before dinner. We give it by subcutaneous route. You can see in the next figure. So this again I have taken it from the KD Tripathi. So here you can see the split mix regime, and here we have given the two doses. One is before the breakfast and before the dinner, 8 o'clock in the morning and 8 o'clock in the evening. And which insulin we have given? It is a mixture of regular insulin. RI stands for regular insulin, and NPH, that is a neutral protamine agonist. So regular insulin, it is a short acting. So you can see the curve. Okay, peak is within 2 to 3 hours and the duration of action is again 6 to 8 hours. Whereas this one, neutral protamine agonist, this is the intermediate acting insulin. Okay, so then same here also, this is the action of regular insulin and this is the action of the NPH. Now, what is the disadvantage of this if we are going to give this? Can you see this one, this lunch part? So, post-meal hyperglycemia will, it is not covering this part. Post-meal hyperglycemia will be there, and then what will happen during the interdigestive period? This one, here, this part. So, here what will happen? Patient will go for hypoglycemia. Okay, यहाँ पे क्या है? Patient will go for hyperglycemia, and here the patient will go for postprandial. That the patient will go for postprandial hyperglycemia, and because during the basal rate it is going to give a more supply of the insulin, so patient will go for hypoglycemia. So next is we have Basal-Bolus regime. Now what is in the Basal-Bolus regime? Basal is, one is we are giving a long acting or ultra long acting, and bolus is with the rapid acting. ऊपर वाले में क्या advantage था? Just we are giving 2 injection, and disadvantage already I have told. Here how we are going to give? We are going to daily 2 to or 3 to 4 injection, or 2 to 3 injection, you can say 2 to 3 injections we are giving. So one is long acting. Here you can see I and this is analog, insulin analog we are giving. So this is a ultra long acting insulin analog is given. Let's say this is a glargine. So you give either in the morning or at the bedtime, usually a single dose, and to cover this post meal hyperglycemia, give every time just before the meal, give the rapid acting. This is the one which is going to give a more euglycemic effect, but the disadvantage is patient may prone for hypoglycemia. So we are giving multiple injection, 2 to 3 injection, that is daily it is required. Patient may go for hypoglycemia. So we avoid this regime in elderly people and in young patients. So these are two regimes, split mixed regime and another one is Basal-Bolus regime. This is how we give. Where else we can use this insulin? Then gestational diabetes. Another one is a diabetic ketoacidosis. This is a complication of the diabetes mellitus which is usually seen in type 1. It is seen in type 1 and we can see infrequently we can see it in type 2. So ketoacidosis, so ketones body accumulation will be there. So what is the main here? Here there is a insufficient insulin that will be there. Insulin deficiency or insufficient, there is a mismatch insulin requirement, that is not meet, body does not meet the insulin requirement, or insulin deficiency will be there, and the precipitating factor here is infection. Most probably it is infection, trauma, pancreatitis. Now what is the pathogenesis? If there is an insulin deficiency, then what will happen? Okay, so if there is an insulin deficiency, so you can see here insulin insufficiency or insulin deficiency, that is going to cause what? Now there is insulin deficiency, then the glucose uptake for which we need a insulin, this won't be there, and then hyperglycemia, this leads to hyperglycemia. If blood glucose level is more, the kidney, it is going to excrete it, glycosuria will be there, and along with the glucose there will be loss of other electrolytes, sodium, potassium, magnesium, calcium. So this leads to osmotic diuresis, and along with that there will be loss of this, and depletion of the intracellular potassium and iron will be there, and ultimately this leads to dehydration. And because of the dehydration, what will happen? Patient will go for hypotension, shock, and because of hypotension there will be reflex tachycardia, and because of the dehydration there will be hyperosmolarity of the blood, and this leads to again hyperglycemia. Now body is not going to take up the glucose, now it is going to get the energy up to provide the calorie. What will happen? There will be breakdown of glycogen, breakdown of protein and fat. All the three things they will be try to provide the calories. There will be breakdown of glycogen, there will be breakdown of protein, and there will be breakdown of lipids. Lipolysis will be there. With the breakdown of this glycogenolysis, again glucose will be released. So it leads to hyperglycemia, and the same sequence. It is going to follow the same sequence. Whereas with the breakdown of the protein, amino acid will be released, and these amino acid, they will participate in gluconeogenesis. This leads to again rise in glucose level. Okay. Now coming to the lipolysis, breakdown of the lipids, this causes the release of free fatty acid, and this free fatty acid, they are taken up by the liver, and in the liver what will happen to this free fatty acid? They will be converted into acetate and beta hydroxybutyrate, and all this will be released in the circulation. So these are ketones body which are released in the circulation, and that leads to ketoacidosis. Now once this ketoacidosis happens, then what the cardinal feature of this ketoacidosis? Patient will go for vomiting, there will be acidosis will be there, and another is this dehydration. Because of this vomiting, acidosis, dehydration, all these they are the feature of this ketoacidosis, and loss of the ions will be there. Now once the ketoacidosis happens, now what will happen? It is going to interfere with the utilization of the glucose by the brain. Now brain also will not be used the glucose. This leads to impairment of consciousness and patient will go for coma. So this is the pathogenesis of diabetic ketoacidosis. Now you have to treat it. So here main is insulin deficiency. So we have to give insulin, we have to correct the dehydration, and we have to take care of this ions, because there is a loss of ions. We have to take care of that, and whatever the cause is there, the precipitating factor, we have to treat that. So first thing is admit the patient in ICU, send the sample and get it done, this all the electrolyte, because depending on that we will be giving the electrolyte. So what we are going to give for the diabetic ketoacidosis? Yes, which insulin is to be given? It is a regular insulin. Now how we are going to manage the management of diabetic ketoacidosis is, so we are going to put the patient on, one is to correct the dehydration and to correct the glucose level. Diabetic ketoacidosis is, one is regular insulin. Now regular insulin, how much is to be given? You are going to give a bolus dose of 0.1 to 0.2 unit per kg. You are giving a bolus dose of this. ठीक है, ये पूरा का पूरा बोलस दे देना, followed by 0.1 unit per kg per hour. ये हर घंटे में देना है. This is important, per kg per hour. ठीक है, and see the response. If there is adequate response, now what is the adequate response? Adequate response means there should be a fall of 10% glucose every hour. Then this is the adequate response. Then let it be this 0.1 unit per kg per hour. But if the person is not achieving this adequate response, then make it double. इसको आप डबल कर दो, 0.1 से 0.2 unit per kg per hour. And till how you are going to, till कितनी देर तक ये करना, depending on the blood glucose level, till the blood glucose level comes to 300 milligram per deciliter. Now you have to maintain this. To maintain this again, now here we are giving per kg. Now we can give 0.2 unit. Sorry, not 0.2 unit. It is 2 to 3 unit we can give, and try to maintain the blood glucose level at this time. Now the second important thing what we are going to give the patient, it is very important to correct the dehydration. Okay, so to correct the dehydration we are going to give the normal saline. So normal saline 1 liter per hour, and decrease it progressively to 0.5 liter every 4 hours till your blood pressure and heart rate, all that is stable, and then make it half normal saline. Now once the blood glucose level reaches this, then what happens? We are going to give 5% of glucose, okay, along with this. Now why this glucose is to be given when the blood glucose level reaches 300 milligram per deciliter? Number one, to provide the calories, okay, to deplete the hepatic glycogen store. Glycogenesis हुआ, glycogenolysis happened, तो hepatic glycogen stores उसको replete करना है to prevent the cerebral edema, and the most important for the peripheral utilization of the ketones body. Ketoacidosis है ना, to remove the ketones body from the circulation we need this glucose. So to remove the ketones body, so for the peripheral utilization of the ketones body we need a glucose. Because of that we are going to give this glucose. Now apart from these are the two main things we are giving, regular insulin and a normal saline. They are the main thing. What else we can give depending upon the this thing. Then the third thing is important thing is we can give potassium chloride depending on the level. So potassium chloride, because it is lost, osmotic diuresis where potassium they are lost, but the serum potassium level usually it is a normal, because from the intracellular potassium it will move out. But once we are going to put the patient on insulin, एक बार insulin डाला, then what will happen, that ions it will be again driven back within the cell. So there will be potassium ion deficiency. So you can put the potassium chloride. Then another thing is what we are going is there is acidosis. So to correct the acidosis we are going to give the sodium bicarbonate, and if phosphate is needed we give that also. And then we treat the precipitating factor. If the person is suffering with the infection, आप उसको antibiotic दो, and accordingly you have to treat. So this is how you are going to manage the diabetic ketoacidosis. Now where else we can use it? Another is hyperosmolar or non-ketotic coma. This is frequently seen in type 2 diabetes mellitus. So here what will happen, severe hyperglycemia, the blood glucose level is more than 600 milligram per deciliter, and severe dehydration. So precipitating factor here it is also a same. Here what is the difference between this? It is a non-ketotic. So in type 2 diabetes mellitus usually we will not see that severe deficiency of insulin. So what happens in hyperosmolar? So this part, ये वाला, this lipolysis, this is not seen. ये वाला part, because there is never a complete deficiency of the insulin. But yes, this part, this one will be there. So important is here dehydration will be there, hyperglycemia will be there, and because of that hyperosmolarity of the blood will be there. So we are going to put the patient on regular insulin. आपका saline भी जाएगा, but the more important is here hyperosmolarity. So patient may go for thrombosis. So prophylactically we have to give heparin. ठीक है, तो इसमें ये एक चीज है, we have to give the heparin in hyperosmolar or non-ketotic coma. ठीक है. So where else we are going to use? Another one is, just now I have told the non-diabetic use of insulin. It is in the hyperkalemia, because once we give the insulin, it is going to shift the insulin extracellular, treatment of hyperkalemia. Once we give the insulin, it is going to shift that extracellular potassium towards the cell. So it will be driven within the cell. That leads to the hypokalemia. So it is used in, this is a non-diabetic use of the insulin. So that's about the therapeutic uses of the insulin. So we use it diabetes mellitus, diabetic ketoacidosis, non-ketotic hyperglycemic coma, and in hyperkalemia. Now what are the adverse effect of the insulin? The most common and the most severe adverse effect of the insulin is hypoglycemia. This is very commonly seen in a patient. So hypoglycemia. So what are the warning sign of the hypoglycemia? Whenever the person will be going for the hypoglycemia, there will be sympathetic stimulation. Because of that sympathetic stimulation, patient will say there will be sweating, there will be tremor, there will be palpitation, there will be anxiety. So these are the warning sign of the hypoglycemia. Once the patient complains with this, immediately give the glucose. But if suppose patient misses this symptoms, then what will happen? Patient will go for the न्यूरोग्लूकोपेनिक symptoms. उसमें क्या है, पेशेंट को विजुअल डिस्टर्बेंसेस विल बी देयर, हेडेक विल बी देयर, डिजीनेस विल बी देयर, फैटीग विल बी देयर, टायर्डनेस विल बी देयर, ठीक है, एंड मसल इनकोऑर्डिनेशन विल बी देयर, ठीक है. And sometimes what happens, if the blood glucose level still falls, means less than 40 milligram per deciliter, then what will happen, patient will go for seizure and to the coma. Now how to treat, because it is very easy to treat. So give oral glucose, 20 to 30 gram of oral glucose, and if the patient does not give a response, again repeat it after 20 to 25 minutes, again repeat the same dose oral. ठीक है, अगर oral से नहीं है, if the patient is not showing the response, then give the parenteral glucose. आप उसको glucose को parenteral IV route से you can give the glucose. And still if the patient is not responding, so first is oral glucose, then parenteral glucose. This is number 1, this is number 2. Still if it is not there, then glucagon 0.1 milligram IV, and very rarely we can give adrenaline. This is a number 4. Then is second adverse effect is insulin allergy. Because of the, this is usually seen with the conventional preparation, and where various proteins, contaminants, they are there. So patient will go for urticaria, angioedema, and patient will go for the anaphylaxis. So any patient if tells about the allergy, switch over to the human insulin. Edema, so this is because of the sodium retention, and for the very short time it is there as person starts with the insulin, and then because of the insulin it has got the sodium retaining ability, so that leads to the edema. Then local reaction, the most important local reaction is apart this lipodystrophy or disfigurement. This is also mostly seen with the conventional preparation. So this is another indication to switch over from the conventional preparation to the human insulin. Then another one is insulin resistance. So insulin resistance, it is suboptimal response of the various tissue to the insulin. And usually insulin resistance, it is very commonly seen with the advanced age, and with the person with the in a obese person, it is very commonly seen. And there are the two type of insulin resistance, one is acute and other one is a chronic. Acute is for a short period, okay? Short period, like if the person undergo for any trauma, any surgery, any infection, or during the pregnancy, then the response will become suboptimal, okay? इसमें क्या है, you have to increase the dose of the insulin, that's it. Chronic is because of the formation of the antibodies, they are formed against the insulin, and this is usually seen with the conventional preparation and switch over to the human insulin. इसमें treatment क्या है, you have to treat the cause, chronic किस वजह से है, whether PCOD or any hormonal Cushing syndrome is there, acromegaly, ठीक है, and in that we will see the chronic insulin resistance, treat the cause and switch over the insulin preparation from the conventional to the human insulin. That's it. So this finishes the adverse effect of the insulin too. Now the important question with this, in all the videos I have told important question related with the insulin. So insulin as well as oral antidiabetic. So long question usually classify or write the various preparation of the insulin, mechanism of action, therapeutic uses, and adverse effect of the insulin. Then the diabetic ketoacidosis, as such it is asked. Adverse drug reaction, it is also as such asked. Insulin resistance, this is also important short note, okay. And then the rapid acting insulin like insulin lispro, peakless insulin, they are the important short note from this chapter. So if you like my video, please press the like button and subscribe my channel. Thank you for watching my video.